Assalamu alaikum, everyone. Thank you so much for joining us on a Sunday morning. It is my pleasure to welcome you all to this session where we will be discussing how we can promote research integrity through capacity building from a Pakistani lens. We also have the honor that Dr. Professor Zahid Bashir, the principal of Shalimar Medical and Dental College and the co-chair of Shaukat Khanum IRB has joined us for this session. So over to you, Dr. Zahid.
Assalamu alaikum, everyone, and thank you for joining us on a Sunday morning. I think we should start with the presentations. The first presentation is by Dr. Mariam Hassan, and this is clinical research in Pakistan, where we are and where we need to be. Dr. Mariam is a clinical research administrator at Shaukat Khanum Memorial Hospital. So over to you, Dr. Mariam.
Thank you, Dr. Zahid. Slideshow. Okay. So how do I play the slideshow? So we need to give 1 minute to the system for this. Okay, thank you. Okay, so my talk is essentially a talk that sets the stage for this session. We'll discuss where Pakistani landscape for clinical research is and where we perhaps could be. Okay, so I'll start off with talking a little bit about the fundamental difference between clinical practice and research. And that how our requirements for integrity vary in the two disciplines. And then I'll introduce you to one ethical framework for research that is commonly used, especially for equity-based research in lower middle income countries, and the concept of having a robust health research profile for a country. And we will apply both of these frameworks to our part of the world, which is Pakistan, using Pakistan as a case study. And we'll see where we are and where we need to be. With research and clinical practice, obviously the goal of clinical practice is to provide treatment and to cure illnesses, whereas for clinical research, our primary goal is generation of knowledge. So there are different goals, different methods to achieve those goals, different justifications for risk to individuals in these two activities. Obviously, they have different levels of uncertainty as well. There is greater uncertainty when one is undertaking research. And hence, as a result of all of this, we expect a different set of obligations when we are doing a clinical practice versus clinical research. Modern clinical research is the result of several events in the last 100 or so years. So whatever way research is being done today and however it is being governed is the result of some key events in history. So most of us are familiar with the Nazi experiments during World War II and how they contributed to the concept of informed consent in research, the issue of unregulated use of thalidomide in pregnant women, which led to children with congenital deformities, and of course the infamous Tuskegee syphilis study, which alluded to the need for greater protection of vulnerable persons. So in an ideal world, integrity should be a regular element of all aspects of research. In practice, it is often a topic that gets attention only when there's a crisis, and then it's put on the shelf until the next crisis arises. And this has been the way the world has always responded to the need for research regulation and our emphasis on research integrity. So there are various frameworks on how to do ethical research, but I'll focus on one that highlights the core principles. There needs to be a good balance of science and a favorable risk-benefit ratio, an independent review, a voluntary consent, a respect for your research participants. And of course, in this world, in today's world, there needs to be an equitable collaborative partnerships globally in research. And I now introduce you to another concept, which is a personal favorite of mine. And those of you who have ever seen me presented before know that I always use this slide in nearly all my presentations. So in the concept of health research profile is that you need certain parameters. You need evidence of work in all these parameters for a country to show evidence of equity-based research. So there needs to be mechanism that prioritize research, resources to do that research, centers to produce that research, journals and networks to package that research. And finally, and most importantly, there needs to be evidence of the impact of that research on health-related policy and practice. But all of this operates within a certain context. And because this context for lower middle income countries like Pakistan isn't great, that is why we continue to suffer from the 1090 gap in research, which is that less than 10% of the world's resources are being used to address problems that address more than 90% of the world's population. So in simple words, what I just said was that firstly, we need to see what do we need to carry out research, the regulations, infrastructure, human resource and funding, and being cognizant of the fact that this operates in a certain context, and then see if there is impact of this research on health policy and practice. And this is what this is the framework that I will use to assess health research landscape in Pakistan. So health research profile and ethical framework for research in Pakistan, using Pakistan as a case study and seeing the good, bad, and the ugly in Pakistan is going to be what I'm going to do in the next few minutes. So most of you do not need to be introduced to Pakistan, but for our international audience, we are a heavily populated country with a population of more than 200 million. Our expenditure, the percentage of expenditure on health is roughly around 2.8%, which is way below the WHO benchmarks. And of course, we have a diverse population with a distinct culture. The healthcare delivery system in Pakistan is tiered, and there's a lot of out-of-pocket expense spending. So the access is patchy, and the public healthcare system is often very fractured. However, despite all of this, there has been a steady rise in the number of publications from Pakistani medical schools. There has been a rise in the number of both public and private medical schools, and some teeny rise in the PMRC budget that Pakistan has used. Up until 2012, 2013, this rise in number of publications didn't really mean that we had publications in index journals. But in the last 10 years, the number of publications from Pakistan has raised exponentially in index journals. They are mostly local, but they are nonetheless index recognized journals. So the number of clinical trials from the region has also grown a lot. So there's a lot of potential here. There's a lot of work that is being done here. But if we assess what informs this work, we see that the funding bodies are largely the industry sponsored research. And then in most cases, most universities end up using their own resources for this. As you can see that, the top funding bodies are either our local national bodies like the HEC or the National Science Foundation, or in most cases, if you review the number of clinical trials happening in Pakistan, you'll see that these are being funded by organizations themselves mostly, or industry sponsors. In terms of infrastructure, we have few sites that can conduct clinical trials, some contract research organizations, some sponsors who are working on research, but very few dedicated academic research centers for health research. And one needs additional logistics as well, not just the buildings. You would need well-equipped centers, and of course you would need human resource. So this is just a non-exhaustive list of the kind of human resource one would need for research. But the number of MD, PhDs, physician investigators, and the rest of the list that I have enlisted here, we don't have enough numbers. There's been a mushrooming of study coordinators after COVID-19, but no plan for their career or capacity development. How research is regulated in Pakistan. We do have a national ERC. Dr. Saima after me is going to be talking about that. A drug regulated authority that regulates clinical trials, a clinical trials registry that is largely non-functional, and then at the institutional level, various ERCs, but again of varying quality. So the general sentiment is that they range from being completely rubber stamping bodies to, some really good ones as well. Common challenges in conducting research here are many. In a traditional society, negotiating the relational autonomy, ensuring voluntariness, avoiding therapeutic misconception, and dealing with the trust deficit that the society has. And when I use the word trust deficit, I don't put the onus on our participants to trust us. It is our failing that the trust deficit exists. We talked a lot about the context within which research operates. So in Pakistan, the context is complex at best. There's a history of political instability, developing economy, inconsistent research oversight, variable regulations, lack of central coordination. And then, of course, this means that our output, however it may have increased in numbers, is not showing high quality in many times. So there have been studies that have explored the understanding of plagiarism in Pakistan, and they have shown a lack of awareness. They have shown a lack of awareness at both student and faculty level. There have been publication frauds reported at international fora for Pakistan. So it's important that while opportunities and challenges both exist for us, we have witnessed a steady enhancement of research activity, but there's a need to assess our capacity systematically and then build on that capacity systematically as well. And it's also extremely important that those of us who work in research come together in robust research networks that don't only work towards training and development, but also towards combined activism to engage with stakeholders for health-related policy making and to ensure that all health practice in Pakistan is truly evidence-based. Thank you.
Thank you, Dr. Mariam. We have time for 1 or 2 questions, and we can do that if there are any questions where everything is fresh in their minds, and a detailed discussion can take later. Dr. Natasha.
Thank you, Mariam. That was absolutely fantastic. It's given us a sort of a really great situational analysis right now of where Pakistan stands. And I was just wondering, in going through all the evidence and the literature that you've gone through over the last couple of years, trying to look into identifying what some of the issues are. What about the actual training of physicians and scientists, where research methodologies and just the subject of research, because that's to me has been really always the big kind of stumbling block. So I was just wondering whether you'd actually come across any work that's done on that, and maybe that's something again that we could look into. Thank you.
Yes, thank you. That's a great question, and it also ties in with our later discussion. So yes, the number of MD PhD in Pakistan is less than 8%. So physicians who would go on to do research, and I realize that MD PhD track is probably not the only way you can develop research, human resource for research. But the issue is that most of our training and development for research is patchy at best. So if an institute decides to do clinical trials, they'll maybe train a few people on GCP. Residents and fellows who have to do research as part of their training would attend a few workshops in CPSP, which are fairly good workshops. But this is not training and development. This is just introducing someone to how to do research, and it is often not enough. And then again, it operates within a certain context. So if people aren't trained well, aren't sensitized well, and they operate in an environment where they have limited time to really pursue this, they don't have protected time for this, they end up cutting corners. So there's emphasis on publication numbers, but there needs to be an equal emphasis on the quality of our output as well.
We have a question from Dr. Aisha and then Dr. Sadia.
Assalamu alaikum. That was a lovely presentation. It's a comment and a question, if I may. When we talk about research being responsive, so within the context of a developing country, what would a responsive research mean, right? Number one. So if you, I'll go put the next question later. Yeah.
Sure. So that's a fantastic question. I think there's extensive literature on the fact that research prioritization in low middle income countries is not done within low middle income countries. Most of the research that is conducted is directed by funding bodies, which are either external organizations. So their interpretation of what research we should do, or what the government may have identified as a priority area. So for instance, Pakistan has always, historically had a national action plan, which prioritized, health areas which need work. And then quite recently in 2020, Pakistan worked with WHO and identified few key areas where, infectious diseases, maternal and child health, and NCDs were also identified as, one of our problem areas which need work and perhaps need prioritization. Recently, when National Institutes of Health were set up, they have, set up a small money pot, which would, ensure that these prioritized areas have some money so that they can conduct that research. So the issue is that we don't have data, national data that truly tells us the magnitude of our problems. So the first step is to really map our problems and then identify which are the areas, which are the problem areas that we would really like to highlight. And this is a capacity that lacks in most lower middle income countries. And that is why it is also extremely important that we have local research leadership and equitable international partnerships where you don't have parachutes coming in.
Yeah. That's a good point, because the principle of responsiveness, which I and one of my colleagues wrote in one of the journals, was that it should not only be a disease that is of importance to the community, the local community, but also that at the end of this trial, the local community is going to gain some
benefit.
So they're not going to be used by the pharmaceuticals or whatever international organizations for their purposes. So the means to end kind of basic philosophy.
Absolutely.
Yeah. So both the things, because I think Emmanuel, which is the framework you're using, is also of this view that these are the two important elements of responsive research.
Absolutely.
So wo aapka jo point hai na ke we should know what you need in this country, and then whatever trials come and match up with your needs should be allowed in. And I think that's where your national level ethics committees.
And more importantly, we should design our own trials and not just rely on trials coming in.
But usme ye hoga na ki if the funding is coming from, let's say, an international organization, wo apni design karenge, but you should definitely have the input. Within this context, this will work. So kind of a practical wisdom thing, which local people, the phronesis thing that I think is very important comes in. So that was important. So that's good. The other thing is, why does CPSP, being the body that I don't know, educates physicians and surgeons, why don't they have a module of research ethics teaching and training, or ethics as part of their curriculum, rather than, like you said, there are a couple of workshops they take and then they are set out into the field, now go out and do this research. So making it part, as in the medical schools, making it a part of their curriculum so that they are sensitized from the very beginning as to what ethics is. It's not just getting, ticking this box and getting the approval or getting the sign on the thing, but what is the foundational principles of research ethics and how it should be conducted so that it is scientifically and ethically valid.
Absolutely. So Dr. Saima is going to be talking a little bit about this, so I won't steal her thunder. Okay. And yes, PMDC actually does require this to be a part of undergraduate curriculum. And we do have institutions like SMDC who work on this. But yes, this needs to be across the board. I agree with you.
Thank you, Maria.
Thank you, Dr. Mariam. Dr. Sadia, will park your question for the end. So thank you, Dr. Mariam, for laying the foundations for today's session on the ground realities as to where we are and where we need to be. The next talk is on ethical governance of clinical research in Pakistan. This is linked with the first talk, and this is by Professor Saima Pervez Iqbal, who is the chairperson of the Research Ethics Committee at the National Bioethics Committee of Pakistan. So Dr. Saima, Professor Saima Pervez, please.
Bismillahirrahmanirrahim. Assalamu alaikum, all of you. Just till the presentation comes up. All right. So for the next 15 minutes, I will be talking about ethical governance of research in Pakistan. I'd like to thank the organizers for having this session in the first place. So, because I think it's really important and not given as much importance as it should be. So my presentation will start off with a disclaimer. I am presenting my personal and professional views and my experience as working for the last 3 years. I've been working as the chairperson of the REC. So I do not represent the views from any organization as such. So I will take responsibility of this presentation. So for the next 15 minutes, I will be talking about what we mean by ethical governance. Then we'll refer to the pandemic of 2020. I will talk about our research review challenges. And also, once the research is improved, what happens then on the ground? And I hope we should learn from this experience and try to map a way forward from here on. So when we talk about ethical governance, it's a very loaded term. There are so many things to look at when you talk about ethical governance. So when you talk about it, it means that you want to set standards for good quality research, which will have an impact on your community. So of course, the ethics of research has to be maintained. You want the results to be valid, and you want the results to be free from bias, so that it could help your community and encourage safe practices and good practices. You would want your public to be free from any sort of misconduct. You want to safeguard their rights. You want your public to develop a trust in you as a researcher. You want to make sure your data has integrity. You want to make sure that your data has followed the scientific rigor. There is accountability, there is transparency, and of course, we will be talking about building capacity. So when I refer to the pandemic of 2020, I did not mean the coronavirus pandemic. I meant the pandemic of protocols that we had to face all of a sudden. So the NBC would be receiving about maybe 2 projects a month, but in 2020, it amounted to like several projects in a month. So that was, so overnight, we saw a lot of research being done. Dr. Mariam has referred to the context of Pakistan. So before I talk about our challenges, let us remind ourselves that we are a low middle income country. We have limited resources. Very few is expended on health, and most of the expenditure is out of pocket and given by the private sector. Pakistan does not have a good track record of producing publications according to what is done around the world. So we are not anywhere in the top few countries of our research output. Dr. Mariam has alluded to this as well. So very few research is being produced by Pakistan. And even that, I think even if it's few, it has to be good research. So some of the challenges that I will refer to that the NBC REC had to encounter during the 2020 pandemic. Number one, flawed research methodology. So the scientists who were presenting research to us, so for example, there was no appropriate control arm, And when we raised that, we had to stress that you cannot do a research without keeping in mind the basic principles of research. There were very poor documentation of the research protocols that we were receiving. So what was written was not clear. And then we asked them to give us more detailed accounts so that we know exactly what you are planning to do and how you're going to do it. I have put the term high profile researchers in inverted commas, because in our context, who is a high profile researcher? I would think a researcher who does good research ethically should have a good profile, but high profile, a lot of people who were not researchers, maybe they were very good clinicians, they became researchers overnight. Then we had researchers or clinicians who were involved in research, and then they're interacting with media. So they were given media coverage way too much than what was desired. And because of that, because they had a lot of media coverage, they also enjoyed a certain political clout, which they tried to force the NBC REC to approve their researches, despite them being flawed. So that is another pressure that we had to face as a committee. So as I said, media hype, because a lot of times the researches that were publicized, when it translated on what came out in the media, people were confusing it as treatment. And one reference that I'll make to it was the plasma trials, the convalescent plasma trials, which were, when submitted to the REC, was not as it should have been. We have had several stalemates between the PI and the REC, and this has happened on several occasions. The PI was not happy with our review, and the PI's team, they would pressurize us, and then we had several meetings back and forth till we were satisfied, or maybe they agreed to change their methods. There were obvious protocol deviations. As I said, as a scientist, when you come onto the media, and then it was obvious that a lot of the research was not, the inclusion criteria was not as it should have been. And this was available in the public domain. So we had witnessed this. Another interesting thing that we saw, because when we looked at a proposal, we said, okay, do you have a clinical trials unit? And how well prepared is it? And so a lot of researchers or a lot of scientists didn't have a CTU within their organization. So that again was a challenge. Or even if there were, DRAP, the Drug Regulatory Authority of Pakistan, they had approved sites for clinical trials, but they didn't have an experience of research. They didn't have the necessary people to conduct that research. There were several researchers which wanted to do, I would say, like stem cell research. And then we would question them, do you have the required certification that is required? And a lot of them did not. So we did not approve those projects in which the facilities were non-existent or only there on paper. Another challenge that we faced was with unfamiliar products like Chinese medicines. They had never been, we were not introduced to them. So research on them was a challenge. So we had to kind of look up the literature, ask the PI for more literature, and only then did we approve those projects. Then there was a research on ventilator development. I'm a family physician by training, so I don't know much about ventilators. So we had to get help from people who were able to help us understand these protocols. But one of the most challenging that we still face today is conflict of interest. So a lot of people here have their own hospitals, and they are the PIs of research being conducted within their own hospitals. So we are not happy with that, because it takes out the transparency and accountability of the process. A lot of researchers have vested interests. They own pharmaceutical companies or have shares in pharmaceutical companies, and it's being funded. So we question that as well. Another issue that we faced was with placebo arms in a trial. So The reference to this is when COVID-19 vaccination was being rolled out by the government of Pakistan to all adults. A lot of research was coming in for new vaccines, and they had a placebo arm. So when the standard of care is to provide vaccination, this research was saying, okay, one group, the placebo group, will get no vaccine. So that was against the standard of care, and we could not approve that because it was not benefiting our population. But we got a lot of flack from the scientists who were behind it, and the researchers were so much, they were saying, you don't want to promote research, funding agencies are not going to, you're not being cooperative, so you should be not so rigid. But we said, it's not fair to our people. So, and it's interesting that established clinicians, established researchers were backing these funding agencies. But we stood our ground, and we also stood ground with the help of other institutional IRBs who were also not approving these trials. So ultimately, the funding organizers, the funding bodies had to change their protocol. Another thing that we're facing is that there is no defined data safety and monitoring board. There is no interim data analysis. So when we were asking for PIs to submit their progress reports, a lot of them were not doing so. So that was another, and we still face that. Therapeutic misconception, when the person is unable to differentiate between treatment from research. This again was available on the public media, social media. So for those of you who don't understand, it's promoting the convalescent plasma. So it's saying that corona ke mareezon ke liye badi khushkhabri, plasma se ilaj mumkin. Again, this was a research, so it was being promoted as a treatment. Again, for the vaccine trials, if you look at the first line, corona se bachao ki vaccine lagaएं और अपने आप को corona se बचाएं. So again, for those of you who don't understand, this was a vaccine trial, and they're stating that get the vaccine and protect yourself from coronavirus. And it's very small. If you look at the blue, that it's a tehqiqi marhala, or a research process. So some unique challenges that we are facing. So we got an emergence of researchers overnight. Because so much money was coming in, so much funding was available, a lot of people jumped on the bandwagon and became researchers overnight. We had issues with the Drug Regulatory Authority. They were approving new clinical sites for research, but again, I think they were not critically analyzing it enough. So that, because we would ask them, okay, show us the clinical trial site. Do you have this available? Do you have the infrastructure? Do you have the people who are manning it? Are they trained to do this research? So, people didn't like it when we questioned them so much about their sites. So poorly written protocols, informed consent, was it truly informed? A lot of it was because of therapeutic misconception. We have seen a lot of unethical research being approved by IRBs. And because one of the process is that you have to show us the IRB approval letter from your parent institution. And when such a research comes to the NBC, REC, we are very critical of those IRBs. And that's why we call them the rubber stamping IRBs. So for those of you who are on IRBs, please, keep in mind that do not lose credibility by approving such proposals. Be critical, because then it reflects on your institution. Then, of course, there was, as I said, compromised ethical oversight. Okay, so once your research is approved on paper and you get the approval from the REC, what next? What happens when that research is being implemented on the ground? So I had a chance to talk to several people who are operating clinical trial units, and this is the information that they gave. So they said, there is a lot of coercion. The clinical trial units directors, they are pressurized to enroll as many people as possible, and a lot of times there is coercion. Then the randomization process that should be followed is not followed quite often. Women, when they are enrolled in trials, they get the shorter end of the stick, because women need to be counseled separately about, especially in drug trials or vaccine trials, that they have to avoid contraception. They are not given enough information on that. And only later on when they do the, I'll be ending soon. Only later on when they end the trial is ending, then they go back and they realize that when they look at the data that a lot of women did suffer from abortions and miscarriages. There is lack of data transparency, because at times, when we get a midterm report about the process, one trial site will report, we recruited so many people, but, and all of them were not lost to follow up. There were no serious side effects. So that makes us question it. Is it too good to be true? And I said another thing is conflict of interest, and very few participants of research, participants within Pakistan, have ever lodged a complaint. Again, are we not giving them a voice? Although it's written in the informed consent form, it doesn't translate. So participants do not get a voice in our part of the world. So what is appreciated? An extensive review with a transparent system, a clear and concise informed consent process, and we appreciate the IRBs identifying their ethical issues and tackling them. So remember, any health research you do will have an impact on science, will have an impact on your society and policy making. So we will talk about the way forward, how to improve that. And I will end here, that the strength of a nation derives from the integrity of the home. So again, our experience has shown that when the PI has integrity, then the PI will also ensure integrity of the research processes. Thank you.
Thank you, Dr. Saima. I'm sure you have a really tough job at the National Bioethics Committee, because I think research in some ways has become a marketing tool as well, where people, the research follows much later, but the hype is created much earlier, even before it's approved or anything else. I think we'll take the questions later, because we have a virtual talk now, and Professor Trudy Lang is a professor of global health research and is the head of the Global Health Network and senior research scientist at the University of Oxford. So he will be sharing his talk now. It's a virtual talk, and I'm sure he's waiting for it. Can we have his talk?
Thank you very much for inviting me to this meeting. I'm sorry I'm joining you remotely, but I'm really delighted to present our work to you and discuss how we might be able to collaborate together going forward. So I'm Trudy Lang, and I'm Professor of Global Health Research at the University of Oxford. And I have the pleasure of leading the Global Health Network, which I'm going to tell you all about today. And what I want to particularly focus on is talking about just building better equity in where research happens and who benefits. And obviously focusing on this wonderful meeting you've got in Pakistan, how we can potentially collaborate together going forward and see if we can bring better equity in how Pakistan relates with the rest of the world and takes part in the whole international research initiative in a much stronger way. So the situation we have is that there's something that's been talked about for many years, decades literally, about the 9 to 10 gap. And this is something that was measured by a whole group of researchers probably about 25 years ago, where they observed that 90% of the research that happens in the world only benefits 10% of the global population. And of course, that population is in the wealthy global north. There's been many studies over the years, and every single one always supports that this gap still exists. And the problem is even the research studies that do happen in the global south, many of those are even led by researchers from the north and are asking question sets in the north. And really, there's a lot to be considered about how much research is benefiting the real priority disease burdens in every country in the globe. And so how can we shift that? How can we change it? That there is a research priority led initiatives in the global south where the right sorts of studies are happening in the right places and asking the right questions, and of course led and rewarded by those researchers in the regions where we need to tackle these diseases. The other important points on this are that although there's been a huge investment and effort and some really great initiatives about research capacity building over the last 20 or 30 years, most of those have been surrounding either one product or one disease area. And this is because most of the research funding comes from disease silos, even in the funding organisation. And so whilst we've made an enormous amount of progress potentially in diseases like HIV, TB, malaria, I know obviously here there's a lot of focus on cancer, and we're all aware how the research funding tends to be led by those diseases, and then you're building up silos of excellence that just focus on those diseases. Now the problem with that is you don't tend to spread that expertise within a health organisation. So you can have a hospital where it has a centre of excellence in, say, malaria or tuberculosis, and then you can step along the corridor in that same hospital and find an orthopaedic ward or paediatric unit where nobody's doing research and nobody has new research skills. So how do you build a strong research infrastructure in that country, in that hospital, without trying to build research capacity overall and moving away from this siloed thinking around a disease or a particular even protocol or product? The other really important point is that research is changing really quickly, and we're moving very fast in terms of how we're moving away from the old observational studies followed by phase 1, phase 2, phase 3 clinical trials, and then they're very separate steps. And it's becoming much more of an organic process to move between those different types of health research, and using really clever new data analysis tools or design abilities. And that's happening very quickly. And the regulators are working with organizations to register products quicker and think about these new types of research processes. But there's a real danger that many disease areas and of course regions in the global south are left behind, and people are just not equipped with the skills to run this type of really up-to-date research. And so these are all the things we definitely need to tackle. So I think there's some good news in this, and I'm going to come back to this throughout this talk really, that whatever disease we're studying, there needs to be many different types of study to address the questions in those that need to be tackled. And then whatever study you're doing, there needs to be a research cycle in terms of designing that study really well and operating it. And the reality is, it doesn't matter if you're working on COVID, as this diagram was first drawn around, or you've come from a background of working on malaria, TB, non-communicable diseases, and of course cancer. The things that you need to do research really well don't actually differ, whatever disease you're working on. And so therefore, we can make a huge amount of progress if we shared our skills and resources between organizations, between countries, between teams, but also across disease areas. And so that we learn all the skills we need to set questions, to run research laboratories, to analyze data, to work with the community. If we could think in a more disease agnostic way and look about building research capabilities overall, because we need research to be embedded into healthcare provision, and we need to connect up research with healthcare delivery. And I think just stepping back and realizing that things that make research difficult don't actually differ will really help us in making some very dramatic strides forward. And so what we've got to think about is how we do that then. How do we make sure that there's knowledge transferred between different disease areas and across different teams? So what we've set up over the last decade or so is what's called a community of practice, and I'm sure everybody's familiar with this, but a community of practice by definition is a group of people experiencing the same problem, a group of practitioners, experts who experience the same challenge, coming together to share their know-how and their tacit knowledge in solving that problem. And then by working together, they all get there faster. So we wanted to create that community of practice in healthcare research. And so what we've done is create this massive online platform, but also operating in the regions through teams and collaborators, which we'll come back to try and enable some of that shifting of expertise from the disease silos into research organisations and healthcare settings, so that we could enable more research to happen in any one given setting or organisation. And we do that by having this digital platform where we've got component separate communities of practice, if you like, that focus on a different topic or disease areas, but they're collected together in this vast online science park. And through our active driving of communities of practice, we can enable knowledge to be transferred, actively transferred between different disease areas, teams and networks and organisations. And that's working really well. And so we've got over 60 of these hubs, and they're transferring maybe tools for doing, setting the question, engaging the community, capturing data, measuring things in the laboratory, and that can be to be shared and exchanged between them. And we're doing very particular things as well, which help even drive this even better. So we run webinars and workshops. We're doing particular programs with groups to develop toolkits and resources that can be shared. We worked with teams to map the process of their studies to work out where the difficulties and the pinch points lie and address those. We support research careers through training, professional development, and all of this works in one collective community of practice. And the outcome of that is we've had over 3.5 million training courses taken, hundreds of thousands of documents have been downloaded and shared. And we work to try and raise standards by sharing these tools between groups. So it's work with one team, it will work with another, and that raises the standards and makes things quicker and easier for everybody. We also want to make sure people are recognised for sharing. And so we're able to issue DI numbers, document identifiers, to anything that is shared. And that means those documents can be tracked, and it also means that people sharing the documents can get recognition and cite that they've shared those, and then they get reward for sharing as well. So over the last few years, we've been working to try and take this approach as widely as we can across the Global South. And so the Global Health Network over the last few years has really become this federated, decentralized partnership philosophy almost, and many coordinating centres and country hubs now exist across the globe. And these are typically hosted by partner institutions who host the Global Health Network Ghana or the Global Health Network Peru, and we've got coordinating centres across Africa, Asia and Latin America. And we really welcome organisations to consider becoming a partner in the Global Health Network. And it's like a franchise approach really, where it enables organisations to take on and being part of this Global Health Network family and deliver some of the tools and resources locally in their healthcare setting, and also obviously have access to these tools and resources themselves, and everybody benefits by this really scaled approach of sharing research methods and tools. Just this year we've been designated a WHO collaborating centre, and this is because we share the drive of the science division within the WHO to try and connect health research with healthcare delivery. And so we're working with the WHO in a number of ways to try and facilitate this embedding of research skills in every healthcare setting, where we can work with teams to deliver some of these research expertise. So how actually do we do this, and how do we work with teams across the globe to try and widen the ability to undertake healthcare research in any healthcare setting? So what this is really all about is trying to accelerate discovery for health by harnessing these mechanisms for doing research, and really pragmatic research quite often, asking questions that are appropriate to that community, working out what could be measured to ask those questions, and working with the healthcare setting to deliver good studies that can be taken back into the community and turned into new practice or policy. So what does this need? This needs capacity at scale. And that means working with healthcare organisations to make it okay to do research, to support research and make it something that's welcomed and encouraged and nurtured in any healthcare setting. Enable that systematic approach to providing an environment for health research to happen. A very precise way that we're doing this is to support Pathfinder projects. And this is where there may be a study that's planned or a study that's already ongoing, or sometimes studies that have already happened. And these could be, any new type of healthcare study, or they might be trying to get new evidence from existing data sets. And so whatever the host study is that's happening already or is planned, we can run a Pathfinder project around that to work out what the barriers and challenges are in undertaking that piece of work, and work with the teams to solve those solutions by finding methods that others have used, and by tracking that project to see where the pinch points are and that others can learn from those. And doing these Pathfinder projects are a really useful way of kind of learning by doing and working out where the areas of difficulties and skills gaps lie. So all of this is about building systems and environment that enable research and data science to happen. And so this could be that within any healthcare setting or research organisation, there is a need for new research management tools and systems, training, career development that can really help research thrive in that setting. And there's any number of ways we can do this through the resources that we have on the Global Health Network, and also with connecting excellence with other organisations that may be very nearby and have research systems in place already to work on a particular disease, and maybe they can be shared with another team, or connecting up disease areas that are working in different locations, but then maybe they've got a really good data management system or a laboratory assay, or perhaps say pathogen genomics tools that other groups could use. So all about working in federated partnerships to share know-how, skills and tools. And that is really helping to drive equity. Underpinning all this, there needs to be really good governance and trust. And that it goes across the board, from working with the community from the outset in introducing research, through putting research in place in any healthcare setting. And of course, use of data sharing and doing the analysis of data really requires lots of these processes to be put in place that create structures of governance and trust. And even these can be shared, and there's lots of great know-how on this now. And so seeing what other teams did in other settings to build this trust and engagement can really help to foster faster and more ethical progress elsewhere. So how could we work together, and what could potentially we do going forward? So many of the programs we run are actually face-to-face and are delivered in hospitals or research teams or universities. And these can be working with particular groups of people that want to do more research, like maybe nurses or community health workers, or anybody across a hospital or an organisation where there's an interest in doing research, but people perhaps feel they don't even know where to start or haven't got the skills to do it. So obviously, there's a vast amount of online learning that can be accessed on the Global Health Network, but we can also deliver research training in person. So there could be that what's needed is access to screens so that people can access online learning, and that might need a facilitator or a room with screens on. And these supporting learning sessions are really easy to set up, and we can work with organisations to support those being undertaken, and then suggest even sets of courses that could get that underway. We work as well to do training in person, and these can happen through workshops or even quite focused topics that can happen in specialised series of training courses that can happen in any research organisation or healthcare setting. Twinning and mentoring is a really great way to have a group maybe that's got huge research expertise within one organisation and group those with another team that haven't got those skills yet. And that can be within even a city or a hospital or even a region, to try and share those skills and bring that equity in where the skill sets lie. Research clubs and clinics are a great idea as well. Rather than having a journal club, you can have a research club in your university or your department or your hospital. And some of these can work then to hone the vast amount of online resources and training that are available, to help signpost those and bring them together and make them focus to your work. And all of these things are really easy to deliver and just need a bit of coordination support. And that's why partnering with the Global Health Network centre or hub can really help access some of these mechanisms that are available. And doing this can really build confidence and skills, obviously, within a whole team. You can really even bring little curricula together that are relevant for a particular research team to give them the skills you want. And we want this to build mission and to benefit. And so I think it's always really good to think of a whole research team, every component members, training drivers in why the research is happening in that rural area and why they need to bring blood samples back to the laboratory is really important, right through to making sure that everybody feels valued and understands the protocol and why you're doing a study. And ultimately, increasing the visibility of research, engagement, and this community that we talked about before, and making sure you're working with the community to set the questions and have research findings taken back. It was all about increasing the visibility of research and ultimately making sure that there are plenty of opportunities for findings to be taken up and recognised and taken into policy and practice. So just coming back to what I was talking about at the beginning, what we're really trying to do with the Global Health Network is understand that tackling any disease requires this whole ecosystem of evidence. We need to do surveillance to understand where the disease threats and what the level of the burden is. We need to do observational studies to characterize different diseases. We need clinical trials then to test any interventions. We always need social science to understand the perceptions and the barriers and how behaviour might change risk or manage disease transmission, or behaviour changes that can reduce the burden of disease in society, such as non-communicable diseases and dietary change maybe. Obviously, laboratories, genomics, diagnostics, these are key underpinning areas of research where it all needs to be tied in together so that your laboratory is connected with your public health benefit, and even designing studies or good diagnostics, obviously really supportive for surveillance and observational studies. We've all learned about disease modelling through the COVID pandemic, and I think this has been a really nice side effect of the literacy around amongst everybody on what even R0 means. But we do need health economics and different type of modelling as well to understand where research can bring benefit and really setting priorities. And of course, we were talking about earlier around how research is changing, and the use of real world data is really coming up really fast and is changing how these sort of distance separation of any clinical trials and real world data is changing really fast. But we need this whole ecosystem, and any one of those types of studies also requires these same component steps to make sure we're delivering safe, ethical and accurate studies. And so what we're trying to do with the Global Health Network is work across all of these areas, because there's the same skill sets that are needed so that any team can tackle the disease that they want to in their community and deliver really good evidence to change outcomes. So just to finish off, we know that the component steps in research and difficulties that occur don't differ between the type of research or even the disease area. And if we work better to share cross-cutting resources and training, then we can drive progress much faster, and we can nurture teams and drive really impressive research teams that can become independent, win grants, become independent and internationally competitive researchers in their own rights. And so bringing together research organisations that we have through these knowledge hubs on the platform that tackle different diseases and different types of research topic, with the vast number of people that come from health research teams and healthcare workers across the globe, connecting up research organisations and the research community and the healthcare community themselves enables this knowledge transfer between health research and healthcare delivery, and increase the generation of evidence and the use of evidence and training health outcomes. And so we really invite everybody to try and help us in this, and we can take this to scale, we believe, and it would be just excellent to work in a much stronger way within Pakistan and see how we can work together to really change the research capabilities within Pakistan and see if we can connect you up better with the rest of the globe and create a whole new future of brilliant research leaders from your region. Thank you very much.
Thank you, Professor Lang. Can we take questions? Any questions for Professor Lang? All right. So it's not a virtual online talk. All right. So in that case, I think we'll take a few questions for Dr. Saima Pervez Iqbal. Sure.
Thank you, Dr. Saima, for such a wonderful talk and sharing your experiences. So, yes, you talked about the credibility of the IRBs and the responsibility that they have. So, one of the pressure that we have felt, and I'm sure that other IRB members who are present here, and Dr. Zahid would be able to relate to that. So there are studies which are approved by other IRBs or at times like other forums. So, and that sort of creates a pressure to another IRB and the concept of IRB shopping. So there would be institutions and IRBs which would be ready to uptake a research proposal in which we might be able to find some flaws or some room for improvement. So in that case, the investigators or the sponsors, for them, it is quite easy to shop around the IRBs. So that's like a challenge. And I would like to have your thoughts on that and I would like to add one comment. So that's the time then when we reached out to you, our IRB reached out to National Bioethics Committee, and that happened during COVID-19, because that was the time we felt that we need to talk to each other. And from previous pandemics and disasters, there is some literature that hints towards or that suggests that the review in certain emergencies and in other cases, or for multi-center research studies, it can be coordinated, or there could be cooperations. So it's a recommendation, and it would be a dream if this recommendation can be translated into an action. So I would like to have your thoughts on that.
Okay, so what I totally get that, because quite often what happens is a project has been approved by a certain organization, and then the NBC does not approve it. On one or two occasions, it also happens that we have approved a project, but the local IRB has not approved it. But that's the beauty of the system, because we're also human beings. We can also overlook things. And if we overlooked something, someone else was able to catch it, if something unethical was going on. Generally, what I'd like to say is that IRBs, a lot of the scientists or researchers have this impression that we don't want to promote research. I think that is far from the truth. If anything, we want there to be more, and we want to promote it. We're all for the researcher and supporting the researcher. I think what is important is the networking of the individual IRBs with other IRBs and with the National Bioethics, the National IRB. The process is now in place. In our last meeting, what they're going to do is now the NBC RAC, the Secretariat, will now look at individual institutional IRBs and certify them. So there is going to be a process, but keeping in mind, I guess it's going to be a slow process. It'll take at least a year for us to then go to several institutions and then certify that this is a credible IRB, because we will be looking at your processes.
So that's just great to know, and thanks for sharing that, because we need to find ways, because IRB, they are under a lot of pressure. I am serving as like secretary to IRB, as well as I'm clinical research administrator. So there is a pressure to promote research. I can
totally get that. Yes. The pressure, how to tolerate that pressure, especially if it's a senior member in your organization. Yes. It's very difficult to say no.
Yes.
Especially if you're in a junior position.
Yes, and what you just shared, I'm hopeful that that's something that can be like to empower IRBs. So, because if we have a credibility,
I would say IRB members should have a critical mind and should have moral integrity and resilience. So the ability to say no, this is wrong. A lot of people don't have that here.
Because we need to remember that IRBs, the members who are serving on IRBs and the IRB support staff, they are of course employees of that institution. So that's like something we need to, that's like one factor.
Yeah.
So, but yes.
Yeah, you need support from your leadership,
Yes.
and provided that your leadership is ethical as well, because we have seen IRB, because when quite times when, you know, in institutions IRB is dubious, we will say, okay, give us your structure of your IRB, tell us about your processes, how do you induct members? And quite often, you know, the vice chancellor will be the head of the IRB, but when we point it out to them, you know, this is not right. You as head of the institution cannot be the head of the IRB. So
Yes,
we need to have more dialogue and discussion on that. People have to realize conflict of interest. I think a lot of people here are not aware of conflict of interest and how the nuances it creates.
So thank you so much. That answered my question, and thank you for sharing your vision. Thank you.
Okay.
We have a question from Dr. Aisha and then Dr. Sadia.
Thank you, Dr. Samina. It was a lovely talk. I have a question and a comment. It's mixed. You were talking about IRBs. My question is, if I am a PI and I get approval of my proposal from my institutional IRB, I have to collect data from other organizations. And then when I take my IRB letter and my proposal to the other organization, again, I have to go through with their IRBs.
Yes.
And sometimes it becomes a difficult process, because those IRBs, again, they want to make changes in the proposal at the core level of that whole process. So how can it be it can be made easier for the researchers, or sometimes the IRBs from the other organizations, they want to almost change the whole of the proposal. It does happen sometimes.
Okay, when you change the proposal, are you changing it for the better?
It could be.
So isn't that a good thing if you...
But shouldn't that be, there should be, if data collection is being done in other organizations, shouldn't it be administrative approval rather than going through with the IRBs? Is it necessary to go through? If one IRB is a certified good IRB, obviously this is coming from you now, that you are going to certify the institutional IRBs. That is also a very good thing. If that IRB is a certified IRB, then
certified IRBs can also make mistakes.
Okay.
I mean, let's be, I mean, we're running, people are running it. We can overlook certain things.
Yes.
I think what I'm trying to say is you may find this a cumbersome process, but if this process is making your research better, then is that not a good thing?
Okay, fine. That is good. But if a PI is going through with, let's say, 5 institutions or 6 institutions, he or she has to go through with a minimum of 5 IRBs. One or two are giving them administrative approval. How would that?
Okay, that depends from institution to institution. So I know for a fact that because I'm from Shifa, anyone doing some outsider coming to Shifa to do research, someone from outside Shifa coming within our organization to do research, they have to take on a co-PI.
Yes.
The purpose is so that there is ownership of that research.
Fine.
All right. So that way, when you have a co-PI who will help you, if anything, that co-PI takes responsibility of getting approval from that organization.
Okay.
So rather than you taking all the burden on yourself, you know, you get it from your own.
The co-PI can take the burden.
The co-PI can do it from their organization.
Okay. Another question is, the members of IRB in any institution, shouldn't they be going through with regular or on-job refresher ethical courses and trainings, so that the part that was being touched by you and Dr. Mariam, that moral ethical values, that boils down to the virtue ethics of any individual, even in the IRB or as a researcher. So shouldn't that be somewhere in our program, in our
Definitely.
structure?
That is another thing that the REC, the NBC REC is going to look into, that the institutional IRBs, how long is the membership for? How many times do you induct new members? What is their training? Do they get regular capacity building workshops? Do the old members get refresher trainings? So we're going to look into that process as well. So yeah. So we're trying our best at our level, and we need support from the institutions.
Thank you, Dr. Sadia. I think we'll take Dr. Aisha's question. But we can take questions at the end as well.
Thank you, Sama. A good overview of the research governance in Pakistan. The basic question which I'm going to start with is, you come under DRAP.
No, we don't come under DRAP. We're separate from DRAP.
But who are you answerable to? I'll tell you why I'm asking you that. Because if you are linked to DRAP and you're a research ethics committee or National Bioethics Committee approvals processor, there may be a conflict here. Do you know?
Okay,
understand what I'm saying?
Yeah, I understand what you're saying.
Yes.
So one thing I can tell you that the DRAP will not approve any research unless it goes through the NBC REC.
Yes. Okay.
This is a given. So DRAP cannot approve research on its own.
Yes.
It will go through the REC.
So I understand that. What I'm saying is, for instance, we have the Health Research Authority, and then we have the Regulatory Authority for, medicinal products. So two different authorities. The scientists go through that scientific review, then they go through the HRA rec committees, research ethics committees. Those are approved, and then the research is conducted, and then it is approved by the Regulatory Authority for the health medicinal products. So what I meant was, if you're not answerable, what I'm trying to say here is, it's a very nuanced thing. If DRAP has anything to do with the regulation of research ethics, there may be a conflict here.
They don't actually.
They don't.
The people, I'm sorry, coming from my experience, the people in DRAP don't have much of knowledge, I could say, or maybe experience.
After the research has taken place.
No, before. This is all before. So once the research is going on, neither DRAP nor the REC knows what's going on.
Yes. Or the MHRA, yeah.
IRB, and then you also need an approval from the national ERC. So there are layers, but the ERC is part of the National Institutes of Health, the PHRC. Okay. They are not linked with DRAP.
Okay. Thank you for clarifying that, because I was getting the impression that DRAP and the ethics committees are linked in some way.
No,
and that is where I thought that there's a lot of, there may be a conflict there because,
No, hardly, because they will only take protocols once we've approved them. So they will not entertain. But you know what, I was thinking that supposing a trial is being done and then neither the NBC, REC or the DRAP can actually see whether the trial is being done ethically or not. So yeah, that's a problem in our system.
Yeah. Thank you for clarifying that, because that suddenly came to my mind. There's something here. Okay. The other thing is, when you're in your rec committees, when you are inducting reviewers, what is the process? Do they undergo interviews, tests, whatever? How does a member, how do you select a member for a rec?
Okay, so once we have our terms, so like 5-year terms, So once members are outgoing, before that, the NBC REC website will announce that we need reviewers and potential members for the REC, and then they will ask for CVs. And that letter will go to institutions. So the institutions will then nominate their best people who can actually give time to these research proposals. And remember, it's an honorary title.
Yeah,
So they
absolutely.
don't get
It's
paid for
honorary
it.
everywhere. It's honorary everywhere. Nobody gets paid anywhere for their committees. Yes.
So, so then they ask for CVs, and then the questions we ask: do you have experience in research ethics? Have you been trained? How many publications, and so on. And then they're selected by voting. So then the members vote, looking at the CVs, and then they're inducted in once we get the numbers. And then we kind of now we've recently taken on new members. So now we're in the process of involving them within our research, and we're hoping that we can do some refresher courses so that they can.
So there's no interview or tests or anything for this
No
committee?
interview or test, no.
Because that's what we go through when we are inducted as rec committees.
No, we don't have an interview or testing process.
Yeah. Okay, thank you.
All right, thank you, Dr. Aisha. We'll go to the next talk now. We have Dr. Mercedes Rumi, who's a project manager and knowledge exchange lead, Center for Tropical Medicine and Global Health. She's traveled all the way from Argentina. So thank you, Dr. Rumi. And she'll be talking about capacity building for research, perspectives from Latin America.
Assalamu alaikum. So I practice it all the morning. So I usually get very nervous when I'm speaking in an audience and such experts. So shukriya for hosting me. And I propose we do a trip, all of us, to the past. Let's imagine we are in the early stages of our medical career, nurse career, biological career. We are left on the ward of a hospital. And the doctor, our boss, tells us to give this medication to 5 patients that have a disease. But this medication has not been proved effective for this disease, but the doctor thinks it works because he thinks it works. So you give this medication to the patients, and you see that in 3 of them, there's a skin reaction. And you go and tell this to the doctor, to the boss, but he says, no worries, just continue giving it, it will work. But you're worried about the patient. And you want to find out if that was just a coincidence, or if really there's a cause behind. But it's your first year in the health career, so you've never done research before, and you don't have the support of a mentor, of the doctor, of the hospital to do it. So then there's one question that arises. Which skills do you need to know to be able to do a high quality research study? Which skills would enable someone with no experience to write an integral research, a high quality research study? So we made a mixed method study to respond to it, and I wanted to share with you the methodology and some of the results, which I hope are valuable for you. But first of all, I'll do some promotion of my country. So my name is Mercedes, like the car, and I come from the southest country in the world. Does anyone know which is the southest country in the world? Not the ones that know me. So it's Argentina, in Latin America. And I grew up in a farmer town, very small town, where most of my friends are farmers, my parents are farmers. And Argentina's main economical activity is to grow cereal. So we grow wheat and soya, and we sell it to China. So actually, we always say we grow what the Chinese want to eat. And this is my town. My house is nearby. And then in my region, which is called the Pampas. We usually, when we are kids, we learn to ride on horseback, and that's typical from my region, the Pampas. And I've studied medicine at the University of Buenos Aires and was part of the neurological laboratory CONICET. And I have to be honest, I can't believe I'm in Pakistan. It's for us a very exotic country. And Mariam and Farah has been excellent hosts, and they took us yesterday to the Lahore fort. And we had amazing food, and there's a lot of music in Pakistan, so you have an excellent country. And we were very surprised with Frank, my colleague, of the level of researchers in Pakistan. So now I didn't came to talk about this, so now I will go to the topic, science. So picking up from Trudy's talk, I work for the Global Health Network. I coordinate the projects for Latin America for the Global Health Network. And let's go back to this inequity. So there's the 90-10 gap that Mariam has also mentioned, where most of the research studies are for diseases from the north, and even the studies we run in the south are targeting the north as well. And I think most of us here are interested in being part of this change, and that's what gathers all of us together, and to work for a fairer world. So I'm very happy that we can discuss later also in the panel discussion how to do that. And we agree that for whatever disease we study, we need the same type of research cycle. So sharing steps and processes and protocols between diseases and between settings and between areas will be very beneficial for all of us. So the Global Health Network, in collaboration with TDR, which is from WHO, has run a study from 2017 till now, and it was published 2 weeks ago, which was responding the question I put at the beginning, and the result was the essential research skills training curriculum, which are the minimum set of skills, knowledge, and key principles that will enable someone with limited or no previous experience to undertake high quality research. And there's the link there, which you can take a picture, or I can share later. So I'll explain a little bit the methodology in case you would like to replicate it. So first of all, we've done a knowledge gap analysis. There was various sources for the gap analysis, and we collected data from 2017 till 2019. And the sources were, for example, research training, needs service, session evaluations from workshops we ran, feedback from completion of e-learnings. We have a lot of e-learning courses for free from there as well. And we got at the end more than 7,000 responses from more than 100 countries, and most of the countries were from the south. And then, so we had all this list of 98 research training themes that came from this gap analysis. But then we needed a group of experts to check if all these needs were really the ones we needed, the essential ones. And so therefore, we did a panelist selection. And the panelists had to cover all health research disciplines, all geographical regions, and genders as well. And it had to be people that were in research for more than 10 years. So the panelists had included stakeholders, research experts, advisory committees, researchers that write journals, policymakers, research participants as well. And when we had that group of panelists, the third step was to find consensus on what were those minimum set of skills. And we did a Delphi study, which was in 2 steps. So the Delphi method, for those that don't know, is combining views of multiple experts to reach an agreement on a subject. So on round 1, on round 1, I'm looking for the numbers. We presented the 98 themes, and we had to we asked the panelists which ones they considered they were essential for inclusion in the curriculum, and we also asked them which ones were unclear, because some themes were not very clear, and also which of the themes which other themes were missing or have been omitted, for example. And from there, we had 98 essential themes that came, and then there were 5 others that were unclear. So then we modified them to make them clearer, and also they have proposed more or less 10 other themes that were not included. All of these went to a second round of Delphi. And in this one, we have evaluated the remaining 55 themes that were not have not classified the first round, and the ones that were edited and the ones that were not included. So at the end, and this was done with the Likert scale, yes, no. And at the end, we had a list of 103 themes, and we divided it together with the panelists into 13 parent modules. So then we had these results, but these results were not stronger enough yet. They have to go through a stakeholders review and validation, and we had to have a discussion on how to implement them. So I didn't put this 103 themes, but I put the parent modules there, like research principles, study setup, community engagement, research themes, all things that you need to take into consideration if you want to do integral research. And if all of these things are taught, then we can assure we are doing well-designed, safe, ethical, and high-quality study. So then these things went through a review and validation workshops. So for this one, we, as in the previous panel selection, the percentage of stakeholders was only 5%. In this one, we made sure there were more stakeholders. Mariam and Farah have participated in this part. And in the stakeholders certification workshop, we had to consider the implications and the applicability of the proposed curriculum for all the global research community. So this workshop has captured feedback from the stakeholders to address any limitations, and fortunately, they have agreed on the themes that the panelists have agreed at the beginning. So the outcome was positive. But then it's of not use if we have those that the curriculum and we don't know how to implement it, right? So we have done another implementation workshop with 250 participants, more or less, where everyone gave their feedback on what would be the best way to use this curriculum, what would be the next steps for the curriculum. And I want to share some results with you. And some of the questions were, for example, that we did to the stakeholders. Are the titles accurate in reflecting the content? Does this address key essential principles of research processes? Is it globally applicable? Would it be relevant to different types of research? So these were some of the questions we have asked and that have encouraged the discussion. So from the last implementation workshop, we have these recommendations. So the workshop participants have agreed that we need to propose varied mechanism of implementation. We need to provide different options because everyone is different, and some will prepare one type of training and some others another one. But some preferred module trainings were, for example, short courses with a mix of online, offline options, because on some of our settings there are unstable local internet connections. And other suggestions comprise Q&A forums, interactive sessions, and combination of self-learning with discussions with facilitators or mentors, which is called blended learning. And there were also other suggestions, for example, so that we have capacity for epidemics. It was suggested that to create a registry of trainers so that it is there and we can contact those trainers whenever are needed. And then providing materials in downloadable formats as well was suggested, and yeah, making these modules, presenting these module formats to the stakeholders and politicians so that they use it in their agendas was already also suggested, which is the next step that we have to do. Problem-based learning was also identified as one of the most effective ways of learning. And also, we have discussed which are the motivations for researchers and students to get trained. And this can be, for example, getting certificates of completion, having this program embedded in a career program, having a mentor, or giving the opportunity to have a facilitator or a trainer. And I've also wanted to, although this was published 2 weeks ago, we had the results. So we started implementing it in Latin America and in Africa as well, and in Asia. And every activity we do at the Global Health Network is responding to the needs and the gaps that we have in the curriculum. So first of all, we divide our activities by the theme, by these parent modules, and then the workshops, the e-learnings, we do respond to those topics. So we invite everyone to help us in this, to work together to increase the research capacity in Pakistan. There's a lot of things in common between our countries. And we have a lot of potential. We just lack investment because we have lots of talent. And with tools like this one, for example, which can be we can scale it up to a global standard, and we can work together to cover all those gaps. And I invite you to join the Global Health Network Asia. I've done a QR code there. And also to join us tomorrow. Maybe Mariam will say this afterwards in a meet and greet. Thank you so much. Shukriya.
Thank you, Professor Lang. 2 questions. We have time for 2 questions. So do we have any questions here? All right, so we'll, yes, Dr. Natasha has a question.
Sorry, I'm having to get you back up on the stage. Thank you very much. It was a great introduction to this really superb resource that we have now access to. And we've learned about. I was just wondering, through this portal, do you also map the network that's in a country? So if you have one research institute or one researcher using the hub in one country and another one in the same country, and you've got like 2, 3 researchers, but they're not in contact with each other, is there a way to kind of connect and keep a track of how this network or how this group is growing within a country? Is that something that the Global Health Network is doing?
Yeah, so we're called Network. So that's a big part of what we do. Of course, we have lots of things to improve, but we do have a tool that is called Site Finder, where you can write down your details, the details of your research institution, what research area you do, and then you can find other sites which are similar. But also we do very organic networking. So my email is there. If you want to maybe partner with another institution from Uruguay, because you've seen Uruguay is very strong on X, then we can foster those collaborations as well. Yeah.
Right. Dr. Frank has a question.
We work with institutions to see what are their strategies and try to harmonize with other institutions. So for example, in Shaukat, Khanum, maybe your area of research could complement an area of research to another university within the country or in a nearby country. So instead of you producing the whole curriculum, you could partner with another institution to be able to leverage the resources. So that's another thing that we do.
I think because one of the biggest challenges we have in Pakistan is something that Professor Lang also alluded to, which were these silos of expertise. And what we really need, a simultaneous effort, is to have a cohesive, platform for all these institutes, for all researchers in Pakistan. And I was just wondering whether this could be a really nice way to do it, is to have that cohesion and have that sort of, unity and trust, because I think Professor Lang was talking about trust within communities and trust within individual research projects. So I'm just building up on that and thinking that maybe this could be expanded to trying to help in Pakistan build up, our own community of researchers and research institutions.
Another thing that we consider most is the context. When we say this is going to be maybe the Global Health Network Pakistan or Asia, we don't know all the gaps or what would be the priorities. So we truly say it's a decentralized franchise, federated in a way that within your group, you understand your needs. And then within that, we can help you with the mechanism to get there. So more what we do is like enabling the communities.
Thank you, Dr. Rumi and Dr. Frank. The next talk is by Dr. Frank Kaguro, and he'll be sharing his perspectives from Africa. And the topic is data science to support evidence-informed policymaking. Dr. Frank is a data science and Pathfinder projects lead, the Center for Tropical Medicine and Global Health, University of Oxford, and he'll be sharing his perspectives from Africa. Dr. Frank.
Assalamu alaikum. I want to take you through data. And unfortunately, whenever, anywhere, people start talking about data, some of the people walk out of the room. So please, unless you have an emergency, don't walk out of the room. And we think data is a structure that is very, out of the blue galaxy material, but each one of you has a phone and you use it every day. And every keystroke you press on your phone, that is data. But you don't know what's happening behind it. Though that has not stopped you using it and finding it useful. People nowadays cannot do anything if they don't have their phones. Imagine your phone has run out of charge early in the morning. Now, take this to research and healthcare. Do we know enough of data that we use? Have we made it useful as a day-to-day tool as what we have done with our phones? So this is the story I want to tell you about. And I also work, I think it's for the introduction, I also work with Mercedes and Professor Trudy, and I have two hats. One is doing exactly what Mercedes said, and another part is on data science and trying to see how we can integrate data science into every healthcare setting. And maybe just to go back, when we speak of research data, let's not think of anything else than the people behind this data. This could be you and me. We could be the ones who are being mapped or analyzed. We do have our needs as cases or healthy volunteers into research. Then when we are thinking of where we need our data to go, these are the faces behind every data. So we have spoken about the 90 to 10 gap. There is no difference in data, and most likely in data, the gap is even bigger. I was listening to a lot of presentations throughout the week. Whenever it came to data, people moved quickly to outputs and what they mean. A slide would stay there for maybe half a second and then quickly people would go. And we heard this morning as well, a lot of the clinical trials don't give interim reports. They don't give the interim analysis. It could be because they don't have capacity or they don't think they have enough to communicate. So data is integral to our work. And just like as a communication tool, if we don't invest in it, that's the part that we lose. So how do we do it in the Global Health Network? In order to analyze, sort of to remove this complex way of thinking and approaching data, we try to work with groups to come up with resources that can be easy to understand, usable, and to help you to maximize what you can do with your research. For example, I don't know if I know how to use this. Oh, yes. You wanted to make a very high quality data science protocol. Remember, every research you do will collect data. So this is something that needs to be thought when you're still framing your question. But then if you want tools to guide you, where do you get them? So the Global Health Network worked with EDCTP, this is the European Commission, to support LMIC countries to develop a toolkit to assist scientists to have high quality data science protocol management or data sharing tools. Nowadays, you will not only make your own clinical trial, but you also want to make sure your clinical trial, once you have your data, you can bring in data sets from other places. It could be within your country, could be just next door or outside the country. So we have these protocols that you can just go download and use. This is one way to not only to share your research, but to help you through the analytical process. So for example, if you go to data development or data management toolkit, it takes you step by step of what standards you should consider, what kind of analysis you should do. Another example is, let's say, you want to do a clinical research. So this is the Global Health Network research cycle. You can go to this resource, click on data science. It gives you several other things or themes you wanted to look at. Let's say you want to look at data capture, data analysis. When you click on data analysis, there are tools, there are toolkits, there are templates, there's training that you can do to be able to take you through of what you can do in data. Or if you want to do data capturing. So these tools, we have made them available, but we didn't wake up and be able to make them. Yes, of course, we are hosted at the University of Oxford, but research in data and analysis, what you type on your phone every day is not similar to what another person types. That is data. The kind of research you do here every day is not the same as everybody does anywhere, but the system of doing it might be the same. So projects you're doing here, if we find ways to work with you, we can package them, put these resources available somewhere, and these can help other groups to work and be able not to duplicate what we do and sort of simplify what data should be. I'll give you an example. So this is my own work, unfortunately. But the good thing I learned from this work, it was to map drug resistance for malaria in Asia. And together with a team based in Thailand, Bangladesh, Myanmar, Cambodia, and Vietnam, we compiled data on drug resistance to be able to know what's going on, what drugs that treat malaria are getting resistant. We could have ended up with a publication. We managed to be able to show where resistance is and probably over time how it has developed. But Was that enough for research? We thought probably no. Despite we have done this, we learned a lot of things about data. Data was not harmonized. People reported different things, and the policymakers didn't understand. If you tell me resistance, you put it on a map, what does it mean? And listen again, when you speak about maps, when you put a map of a certain country next to another, and when the problem is on another country, it feels like you're pointing fingers. So we had to learn, even if we are putting data on maps, how should we put it so that people can understand, leave our political, geographical, cultural biases, and be able to use it as a tool. So we had to learn all that, but that was not the end of the story. The end of the story came because we wanted to come with policy-friendly maps, so we had to get down to that, develop toolkits to help other researchers who do similar research to be able to do this. And definitely, at the end of the day, be able to map this. We package these materials, put them on a resource that can be accessed. It's called WAN, Worldwide Antimalarial Resources Network, which is also hosted within the Global Health Network. Therefore, data, just like what we're talking about in research, has a research cycle, but in the middle of it, there is a population behind it. So when we are learning of, or we are planning our research, we're capturing data, we're thinking of data sharing, data governance, outputs, we need to be able to create outcomes and be able to embed it in our healthcare setting to add impact. And Mercedes and Trudy mentioned about this. So we are here, by the way, you have seen someone from Africa, someone from Latin America, and where is someone from Asia? So we also have our regional coordinator for Asia, Dr. Salvia, who will be joining us tomorrow virtually. Unfortunately, she couldn't make it to this trip, but the plan was all of us to be here. The aim is, well, this was thought about by a group of colleagues, but for it to have context, it needs to work with the people within that region. And for data science, we have this community of global health data science. And here, it's an open resource which we ask, if you're any data scientist or you aspire to become a data scientist because you already are, you're using your phone, you're typing a lot of data, you book for food, you pay, all this is data. You can go put your details that you want to corroborate, and we can link you up with similar groups working in similar research. Or you want to train your group on a certain skill. When you come to this map, you can be able to see where you can find that skill set. Or since we are here, we have our coordination or we have our website, you write it to us and we can put you in touch with those groups. I can tell you an example. A call came when Dr. Mariam and Farah reached it to us. They wanted, why shouldn't we write a proposal on creating a network for cancer research with other LMIC countries? We worked with our partners in Latin America, and I think in a span of 1 or 2 days, we had a consortium of researchers from Africa, Latin America, and Asia writing a grant proposal together to submit. So these are kind of collaborations that don't duplicate work and make us work in sort of a harmonized way to leverage what we have. Therefore, if you feel you could be involved, we also sort of create user-friendly tools to help people throughout the journey. I'll give you an example of what Trudy mentioned is Pathfinder projects. Let's say, even in IRB, where we collect a lot of research, or a clinical trial, you want to create an ecosystem so that if there'll be anybody else coming to do similar research, they can adopt your methodology so that they don't start from the beginning. So we have this, what we call Pathfinder projects, which maps the study and track it throughout until publication, and how it engages the community. And these tools help us, let's say either it's your cancer project, it's antimicrobial resistance, or it's this is COVID data. What it has in common are these protocol harmonization, data capture standards, data preparation. Everyone works through this. So once we learn from different studies, we can be able to create excellence around how do you do protocol harmonization across different studies. And by working with different communities, because knowledge is not stagnant. Knowledge needs to move, to change, and adapt to the context and topics. Therefore, there's a lot that we could learn from what you guys are doing here that could be very useful to another world, but also can be useful to your other colleagues in another province. So, for example, for the Global Health Network Africa, we are currently working with different groups to start these research clubs, data clinics. From Mercedes, we learned that there are competencies in research that if we train different groups, we are sure they can perform quality research. But then knowing is not enough. We need to create activities to give people knowledge. So through research clubs or data clinics, all these Pathfinder projects, we can be able to translate the knowledge that we have to train more people. And it's not enough. We don't want to train, we don't only want to do research. We want to inform policy and be able to impact in our communities. So we are also working to establish what we call policy labs or policy clinics, where you come with your proposal. Maybe you didn't think of how would you transform it to policy. And then you can sit with peers and they can say, okay, maybe you needed to do a school campaign. Work with the students, talk to them what you're doing, and then they'll tell you if they are going to adopt a technology or new diagnosis, how would they be able to do it? And a very big part of our work is we need resources, we need funding. But if you sit in your silo, it's very difficult to access some type of funding. But coming together really helps to be able to build that. Unfortunately, research, governments don't usually fund a lot of research. Therefore, we still have to appeal to what is possible or what is available. Therefore, this is a part and parcel that we can look at. Therefore, you can join, we can build this together. What we have tried to do is to make sure that, for example, with DOI numbers, digital object identifier, once you share, even if it's an SOP that you want to scale, we publish it, we give it a DOI with your authorship. So at the end of the day, it's not that you have shared your tool, but you can assess the impact of your work. So if it gets citations, if it gets used everywhere, we can be able to track and see where it has been used. So this, we think it improves South-South collaboration, and also we can develop a lot of standards in the curriculum to help our communities. So as we said, we'll have a meet and greet and we'll talk more about it tomorrow, but we think we could share with what we do in other places and it might be useful for you. Thank you.
Thank you, Dr. Kagoro. We again can take one or two questions now and then the rest at the end. So any questions for Dr. Frank? All right, Dr. Farah has a question.
Thank you, Frank, for this wonderful presentation. So it's not a question really, it's a comment. I know very little about data. And when I asked this question, I was like, people would know about my ignorance. So because I would know that the data can be used to, data is mostly working in a hospital setting. The first thing I would think about is like data is medical records, and medical records can be used for retrospective chart review and producing a publication. So today when I hear from you, what I understand is, thank you so much for sharing this. And I think I learned a lot. And I understand that I need to learn a lot from you as well, because how we can make use of data, not just to make a publication, but the potential and the magic when we come together, the data can be, we can share our datas, and we can make efficient research outputs. We can collaborate with others, and that's one way we can identify, or we can learn together. So it's more like a comment for you, and for me, I understand that I need to learn a lot from you. So yeah. Thank you.
Thank you. And you said it right, that we think we know about data, but sometimes either we oversimplify or overcomplicate it. Let's say, for example, medical records. And what we think of them, mostly you'll go to this room full of files, and someone is sitting at the desk trying to put all those files maybe in a system. And maybe that's most of our context when we build. But in reality, each of those files is a patient. And when that data was being collected, they were getting treated. The objective of the patient was to get better. So that medical record system has to make the patient better. Another way of looking at it is you are a hospital administrator or a clinical trialist. Your objective of having those medical records is at the end of the day to know what do they have inside that will affect treatment or even change policy. The mechanisms now of making sure that it becomes an information center that gives you insight is what makes it complicated, but you can build this system slowly with other people to get there. But thank you.
We have it.
Yeah. Okay, I just wanted to ask something, Frank. When you talk about data, I didn't understand when you talk data ownership, who owns the data? Because this is a very sensitive issue, even in Pakistan. So institutions tend to hold on to their data, even sharing your data with another institution of your own country or internationally. So has there been any work on ownership? Or because now you're talking globally, I think it's everyone's data, isn't it? So if you could elaborate on data ownership.
Yeah. Thank you. I'll come back here. But first, before I get there, I'll speak about your phones. Did you take a photo today? Or did you write a text? Do you own that data? Or do you think you own it? Did you send it? If you sent it to someone, you use an application. That application is hosted on a server. The person who controls the server can be able to see and learn what you've added, unless there is an encryption that is added. Encryption is more like causing, blinding. Yeah, that's what they say. When you send a message on WhatsApp, they say this is protected by end-to-end encryption. It's just that we have blindfolded people not to see, but if they make a lot of effort, they can see. So the concept of data governance, for example, let's talk about clinical trial data. Most patients don't understand a lot of ethics around data, but then we have institutional review boards who make sure all protocols follow certain procedures. And there is also government regulation. There are regulations that don't allow certain type of data to go without being aggregated, disaggregated data not to be shared across country. So custodianship goes through different levels. So we try as much as we can to make sure the patient understands what they provide and they give consent for data to be used. But then as a trial manager, you need to follow a certain guideline to have custodianship to protect the patients. But at the end of the day, also the government. Imagine now we have 10 projects. So data governance can be quite diverse complex as well. Therefore, what we think we can do to help is to learn what are different data governance requirements or guidelines we can learn from different studies. So for example, with Pathfinder projects, oh my slides are out. For each, for example, let's say it's a cancer project, it's a infectious disease project, there are different requirements for data governance. If we learn across different projects, we can be able to advise people that and train them and even develop training that if you are developing this type of study, these are the data governance skill sets that you need to provide so that people can learn. So it's not a question of this is it or this is that. It varies a lot with context, but it can be built upon. Yeah.
So Frank, what is your take on anonymized data? Because we see that the data can be anonymized at first, and there are certain conditions when we say that certain types of approvals are granted on the condition that the data would be anonymized. And I've been learning, I'm not really sure, as I told you earlier, that I know very little about data, but it seems that the data can be de-identified, and there is a potential that it can be re-identified. So it seems that the de-identified data, the term is no more valid, if I could say so. I'm not really sure. So what is your take on it? Thank you.
Thank you. It's a very good question. My field is spatial epidemiology. I make maps. And one of the work I've done was to look for cases of a disease to where people live and put it on the map. So imagine you're a patient, and then in future you see a map, and the Frank tagged your home to that disease. Yeah. Despite I did not put your name, but you can be able to see on a map and say, that house, I think that's where Dr. Farah lives. So the concept of de-identification or anonymity has several levels. So there is anonymity at the level of the background information, but then it depends with also sensitiveness of data. People wouldn't mind if you want to say what they eat or what do they do as a physical activity. But if when it comes to diagnosis of maybe Ebola, people would want you to protect them as much as possible. So it's a titratable scale. So let's say, for example, for cancer patients, we know once we have two drugs we are trying to test. There's a moment when we might, within the interim analysis, why it's very important, we might realize one drug works better than another, or another causes harm. We need to make sure we're able to identify who are the patients that might have been given a harmful drug to be able to protect them. So we need to be able to anonymize data to a level that we can be able to de-identify and protect patients when needs be. But then that's when the IRB needs to advise you when it looks at your proposal of how to arrive there. But what we can do also, there is one of the causes that we have in the Global Health Network is research ethics. And it has been, I think it's been downloaded or used more than 6 million times. And it speaks about de-identification, anonymity, and how to engage. Yeah, thank you.
Thank you, Dr. Frank. I think we're almost through our time today. So just a minute. I think we had some excellent talks today. The first two talks by Dr. Mariam Hassan and Dr. Saima Pervez were in the local context where we are and what we need to do. The next three talks by Dr. Lang, Dr. Rumi, and Dr. Kaguru gave us a global perspective and gave us what opportunities are available and how we can network. For me, I think the important thing is that research is something that has always been there probably for human history. And whenever there was a conflict between creating new knowledge and not exploiting or not harming patients, that's where people sort of swayed to one aspect, one side. And usually the researchers swayed towards his research rather than protecting the patients or their rights. And when some gross things happened, then came these ethical regulations and ethical guidelines, and they sort of created a sieve, and you had to pass through that sieve. And the sieve is for researchers was something that in some cases it was perceived as hampering research because it created a boundary, it created an impediment. But that sieve is there to stay. And I think over time that sieve is going to become finer and finer. And it's become pretty fine in the West. In underdeveloped countries, it's not as fine yet. And that's why a lot of research from the more developed countries is coming into the underdeveloped countries. And in a country like Pakistan, ethical research or IRBs or the National Ethics Committee is something that's a rather recent phenomena. But the way forward, I think, is capacity building. The sieve is and has to become finer and finer. But at the same time, we have to realize that it can only create a balance if we have capacity building at the local level and at the national level. As we've talked, that the IRBs at local institutions vary in their expertise and in their protocols and their SOPs. So that's where I think the effort should be, and that's where we should put in a lot of, and I would also emphasize that that can only happen if we collaborate. So there are institutions that have well-developed IRBs, and the National Bioethics Committee has the expertise there. So I think the next future has to be capacity building at the institutional level. And that will make the work of the local IRBs and the national IRB much easier, because things would come to them in a more refined fashion. And I think that would lower their effort as well. The talk by Dr. Frank on data science to support evidence, this is something I think it is very current, is very new. And data ownership is something that is now coming up as a major issue. Again, I think if we look at the global picture and the global emphasis, there should be more data sharing and there should be more collaboration, because it's only then that we can have an impact on a global level. So I think this, and the larger the database, the more robust will be the research, and the more robust will be the outcomes of that research. So I think that again is very important. So I'd like to thank you all once again. I think the people from the next session have started talking, and thank you.
And just one final comment. I'm glad that we all agree to collaborate and work on capacity building. This is exactly what we will be working on with the Global Health Network from now. And tomorrow we have a session planned at Shaukat Khanum. Some of you already have those details, and we'll be happy to share the, further details with everyone. Please do join us for that conversation, because that conversation revolves around these very needs that we have identified today. Thank you. Thank you so much. This was a